So today I want to talk about the subject depression. Misunderstood, like pretty much everything I talk about is very misunderstood. Depression basically is not just feeling sad. I mean, we all have times of feeling sad when we lose our pets or when our pets get sick, we lose a job, you lose a relationship, so there's reasons to feel sad. I mean, if things like that bad happen and it doesn't bother you, there's something wrong with you. So there's the normal sadness from life and that we expect, but then there's a more pervasive condition called depression. So how to know the difference? Well, if you have depression, it's going to really more have an impact on your life, and it's more of a day-to-day issue. It's not just something that is there one day and gone and then comes back a couple weeks later. It's a daily thing. Like I said, like say you lose a pet, or like I said, I say a pet because I'm a cat fanatic, and when I lose one of my cats, I'm very sad about it, of course. But then, when I get a new cat, I feel better, and, you move on in life. But with depression, like I said, it's more pervasive. It affects your life more, it affects your functioning in life. So that's the one big thing, is understanding the difference between normal sadness and depression. Also, it happens a little bit more in women than men, and the reason why more in women is because women have more hormonal changes in life than men do. Because the main reasons are depression, and any of the things I talk about is genetic predisposition that runs in families. So you take a family history, probably one of the parents had depression. You might see alcoholism, you might see other things, but you're going to see it in families. Women, you got puberty, you got premenstrual every month, you got postpartum, you got premenopause, perimenopause, postmenopause. For men, we got puberty, and we got, I call menopause. Menopause, or we call midlife crisis, is when hormones start to change in men like they do in women, but just at different hormones. And with men in particular, are more difficult to treat because men don't like to display signs of weakness. Men try to see if they can brush it off, and men feel more embarrassed about it. And women are much more open and much more communicative and understand more. But men are much less likely to take a medication than women are. So that's kind of, I'm of course generalizing because you can see that with both people, both sexes. But that's what I've seen mostly in my practice is the case. Different types of depression. Dysthymia is more of a minor kind of low-grade depression where it maybe is not so every day, but it kind of comes and goes a little bit. There's different, we call the DSM-5, the diagnostic book about psychiatric illnesses. They got that, they have minor depression, they got major depression. But the main one, the most common one is major depressive disorder we call MDD. So MDD, major depressive disorder, is definitely the most common by far. We got bipolar depression. We'll talk about that in a moment too. But that's basically when we start to see this. That's what hints that there's a chemical element here. People try to, again, there's other things besides medications, of course. There's therapy, there's exercise, which I encourage my patients to do. There's other things to do besides medication. But at the end of the day, medications are really extremely helpful when it comes to the treatment of depression, anxiety, other things that we see. And there's a lot of interplay. I mean, a lot of people, there's an interplay between depression and anxiety. A lot of people have both of them together. Maybe one predominates more than the other, but a lot of people have them both. Extremely common. So as far as what to treat with beyond counseling and beyond exercise, if that's, again, counseling can be very helpful, especially when people have issues, unresolved issues, family problems, marital issues, whatever. Counseling can be very helpful, but at the end of the day, they say, yeah, it helps me this and that, and you can learn coping strategies and things like that. But at the end of the day, it's really a chemical thing that can be easily dealt with. So the first, the most common thing that doctors give is an SSRI for depression, selective serotonin reuptake inhibitor. If you've watched my show, you know basically how I feel about this class. I think they can be good for some people, but the problem with SSRIs is they can be very incomplete. Most doctors think they're the first line treatment. I've been disagreeing with that for about, 33 years now? 32 years now. Because at the time when I was, again, just out of training, starting my practice in the early 90s, we had 3 SSRIs out at the time, Prozac, Zoloft, and Paxil. In 1993 is when the first SNRI came out, called Effexor XR. And that's when I really started to see like a big change. And I started to see a separation from this class to this class, better results. Not only better for depression, better for anxiety, and then better for body symptoms. We call somatic symptoms body aches and pains, which again, I tie more into anxiety disorders when we talk about that. But again, if the body aches and pains are happening with depression, then it's usually because there's some anxiety going on. Because depression alone doesn't typically cause those physical symptoms. It's usually anxiety that does that. And that's why there's this coexistence that's happening. So why are SNRIs better? They're more complete. They do more. They're balancing 2 chemicals instead of 1. And so SSRIs, they work on serotonin, and they get serotonin moving that away, which is great. And then it connects to the next cell. And then but with SNRI, you got norepinephrine, and that connects to the next cell, and that's great. And it's usually better because again, it's just doing more. It's just doing more than balancing serotonin only. Then you get both of them together, and it's just better results, more complete. So the statistics are basically with major depressive disorder, the SSRI improves the condition about 35%. With an SNRI, like Effexor, about 45%. So it doesn't sound like a lot, like 10%, but it can. That's quite a bit of an improvement when it comes to these conditions. And since then, now we have 8 SSRIs instead of 3, like when we started. We have 8 of them. Now we have 4 SNRIs now. But they've been generic for years now. The only antidepressants that are not generic now is Trintellix, which you might see advertised on TV, but that's the name brand antidepressant left. Well, we'll talk about another name brand in a minute. So what happens when let's say it's a depression and we don't see improvement with balancing these chemicals, well, then I stop it. If we don't see improvement, then there's no reason to take it. Usually it will help. Usually with depression, 1 or both of these chemicals are involved. And again, if someone's on an SSRI and they're getting pretty good results, I say, okay, let's try switching to an SNRI and see if it's better. And then if it is, great. If it's not, you go back to the SSRI. So let's say there's still residual depression like there often is. Well, now I'm thinking about dopamine. So now we got Wellbutrin, which is a norepinephrine and dopamine reuptake inhibitor. So what that does is it really a little bit of norepinephrine, not a lot, more on dopamine. And what does that do? Lifting out of depression pretty quickly and easily. Motivation, drive, focus, improved memory, happier, positive. I call it the wow of Wellbutrin. So the people who understand that dopamine, when you boost dopamine, it's a great feeling. Not for everybody, but for a lot of people. But nothing's for everybody. I mean, you have to be realizing this field of medicine, it's trial and error. We got to test things out. We don't have blood tests. We don't have scans. We don't have anything to go by except for a history, listening to my patient, getting a good history, figuring out what chemicals are involved, trying things, seeing if they work. If they don't work, you take it away. If they do work. So it's a lot of this trial and error. I call it the rational trial and error approach. But again, there's a basis to the trial and error. It's not just throwing darts at a dartboard. there's a reason I do everything I do. There's a reason based on their history and what they're telling me as far as what I choose for that person. And so once I hear their symptoms and get to know like what does what, it takes a little bit. If something doesn't work, I take it away, and then I figure out, okay, well, it's got to be this, and then it usually is. So usually if I don't get it right on the first try, I get it right on the second try. And if I don't get it right on the second try, I get it right on the third try. So we also call it the rational polypharmaceutical approach, meaning, you typically have to combine medications together to get to that 100% mark, which is what we call remission. So full remission is where people get completely well, no more depression, other than the occasional sadness for things you should be sad about, but not this daily pervasive depression that people suffer with. So let's say we've explored those three chemicals and we're still not there. Well, there's a couple things to look for. There's GABA and glutamate. So GABA basically is the main, we call it inhibitory neurochemical. What that means, if we get GABA moving this away, it calms the system down. But there's a medication called Lamictal, which basically it attaches, but it slows down glutamate. So it slows. And when you boost glutamate, it makes you feel, it improves your mood. And we'll talk about glutamate in a moment. But when I think about that, and if I'm thinking about, well, I get a history, and if I think it may be a bipolar depression, and the difference would be is if people get better, then they kind of fall back into depression again. Then they kind of get pulled out of it eventually. So that could be a bipolar depression if it's we call cycling, if we're seeing like it's changing. But there's a very new and exciting medication called Auvelity. And Auvelity is it's actually the only new antidepressant that's come out in many years. And Auvelity is a combination of Wellbutrin, which works on dopamine and a little bit of norepinephrine, and it also works on glutamate. So it actually boosts the chemical glutamate, which again is we call the excitatory chemical. So when you boost glutamate, it improves your energy, it improves your mood, it makes you, so when you combine two stimulating antidepressants, Wellbutrin, and actually the component that boosts glutamate is dextromethorphan. Now dextromethorphan is like cough syrup. But it's not just, you can't just swig cough syrup and help. It's not that. They've engineered it, a certain way where it's just, it's much better than trying to do it over the counter. They've perfected the dosing and everything on it. But it's a really exciting product. So if I have a feeling like I don't think it's a bipolar depression, I think it's a unipolar MDD. And they're not in remission, which is our goal with whatever I've already tried. Then I try. Well, let's say in the case of Auvelity, you don't use it with Wellbutrin because it has Wellbutrin in it. We'd stop the Wellbutrin. So what's the indication of that? Like I said, either if Wellbutrin is working pretty well but not great, or if Wellbutrin doesn't do much, or if Wellbutrin works for a while and then it poops out on us. Then that's a feeling like, okay, well, I know dopamine's involved, obviously, because that's why it helped before, but there's another chemical involved, and that's why I would think Auvelity. Now, let's say we try Auvelity, it doesn't work, or it's not tolerated. Let's say it makes them jittery, it makes them like nervous, feeling, okay, well, that's not it, take it away. Maybe go back to Wellbutrin, and at least we got somewhere with that. But now I'm starting to think about Lamictal. So now Lamictal basically, it actually does the opposite. It actually slows down glutamate. So when you slow down glutamate, it's more relaxing, but Lamictal is for what we call a bipolar depression. So it's not, when we think bipolar disorder, we think about mania or hypomania. Well, we don't think about the fact that it's normally, most of bipolar disorder is spent in depression, not in the other cases. The vast majority of the time is depression. So Lamictal can be very good as I call it the last piece of the puzzle. Sometimes I put that together and everything's good. Everything's steady. You don't get the dips anymore. Everything's great. Other things about depression that are important. There's a lot of misconceptions about medications out there. There's this fear, and if you read about antidepressants, and this came out years ago, this fear that antidepressants increase suicidal risk and ideation. Bottom line is complete rubbish. That's not the case. Now, where antidepressants might increase suicidal ideation is if it's misdiagnosed and it's actually a bipolar disorder. Not even usually bipolar depression, usually a higher grade of bipolar disorder. So if someone's bipolar, and again, a lot of time bipolar is spent in depression, it's possible that the antidepressant will take them out of the depression but pull them into a manic state. And that's maybe where the risk is. So when they studied it, when the FDA and the government studied this, they didn't really specify who had what. They kind of lumped everyone together who had depression, didn't really pick out like, well, this had this kind of depression. They didn't do that. They just throw everyone together. And then they got the statistic that it increases suicidal risk in adolescents and young adults, especially. And the problem when that came out, and at the time I knew that it was a very bad thing that came out, because what happened then is before they came out with that warning, suicide rates had been plummeting down. Ever since Prozac came out, the first SSRI came out, suicide rates were much better after that. And at the time when they did this warning, I was very upset when they came out with that, because I knew it was a lie. I wrote a long editorial to our local newspaper. It never got printed, but I was warning that this is not going to turn out well, and I was right. So ever since that, suicides went up. Why? People got afraid, so they either stopped their antidepressants. Parents would stop their kids on antidepressants because kids get depressed. I mean, normally. Not so much younger kids, but teenagers is where it often starts. Middle school especially, high school. So a lot of times when they pulled people off of things because they were afraid, and the problem with that is then they get depressed again. And now if you're going to have suicidal ideation, that's going to get you there. Having depression untreated, that's what's going to get you to suicidal ideation. So, so the problem is if you misdiagnose something, it can have a bad result. But if you do the diagnosis correct, and if you do things carefully and not rush things, because if I'm giving an antidepressant and all of a sudden I'm seeing people become unstable, I pull it right away and I move the other direction. I put people on a mood stabilizer. I think, okay, well, this person's bipolar. I got to stop the antidepressant. I got to change my thinking here. I got to switch completely. And then I go the other direction. But it doesn't mean that later on, because even people who have bipolar disorder, and again, I have another, if you want to learn more about bipolar disorder, watch my show. I have a whole show on just that subject. But if it's bipolar disorder, you have to address it in a different way, where you have to combine mood stabilizers with antidepressants. So, I mean, the closest we can come with this subject is bipolar depression, which is, again, the majority of bipolar disorder. So anyway, but the good news about depression is it's extremely treatable. I'm usually able to get people fully better within 2 or 3 visits, usually. I work quickly. I do things quickly in my practice. Because I know that when people are miserable, they want to feel better. And the other myth out there in this field of medicine is that it takes antidepressants 4 to 6 to 8 weeks to work. That's completely nonsense. It's never been the true at all. Antidepressants should take an SNRI is quicker than SSRI, and that'll take maybe within a week to work. Maybe a little bit longer if we have to go higher in the dose. An SSRI, about 1 to 2 weeks at the most. Lamictal is the slowest one. So Lamictal might take about 3 to 4 weeks to really see results. So that's the slowest medication I work with is Lamictal. But it's worth the wait, because when Lamictal works, it's a game changer. It totally changes everything. And so, but yeah, there's a lot of misconceptions in this area of medicine. And there's a lot of anti-medication mentality out there that we're over-prescribing and big pharma, this and that. And I get it. I understand that, big pharma doesn't always do that. I don't always agree with everything they do. What I do like about them, though, is that they provide me with these, and other doctors, with these amazing tools to help people. And so they're not always the bad guy. They come out with these things that are very helpful for many of my patients. And so you don't have to live with depression. There's no reason to. It's very treatable. My success rate is virtually 100%. If you stick with it, get the combination right, then people can live a happy, healthy, functioning life. And that's where people should live. There's no reason to live with these conditions when you don't have to. And again, if you can't find a doctor who can help you, or you're getting frustrated, or doctors are doing the same thing over and over again and not getting results, you want to contact my office. I'll try to help. I do see people virtually, out of state, if you're not in my area. So, or if you know someone who needs help, then contact my office, and I can do what I can to help. So I hope you learned something about this. If you have any questions, feel free to contact me.